Well, so today we are talking about wounds and inflammations. My name is Benjamin Kiri Ampa, and I hope in this period of the pandemic, you are all taking care of yourselves. This is something that doesn't usually happen, a virtual class, but we will manage and cope with the situation for now until we meet. All right, so at the end of the lesson, I know that, or it is expected that students would know the definition of wounds, the classification of wounds, the types of wounds, the physiology behind wound healing. They would also be able to define inflammations and the physiology that goes into inflammations and the attenuation of inflammations and so on and so forth. Okay, so without wasting much time, what is wound? Before I come to the definition of inflammation, I would want to define wound and then I'll come to inflammation. Wound is a break in the continuity of the skin with or without the overlying epithelium. If I say with or without the overlying epithelium, what I mean is that whether once you get an injury, if there is a break in the continuity of the epithelium, it is a wound. If there is a break in the continuity of the underlying epithelium, it is a wound. So if you hit your hand on a wall and then your hand, that part of your hand gets swollen, the skin hasn't broken, but we still classify that as wound because there is a break in the continuity of the underlying tissues. So you don't define wound and end it at break in the continuity of the skin, but it is with or without the overlying epithelium. That is why a contusion is a wound. Now let's come back to inflammation. Inflammation is a localized vascular and cellular response of the body to the injury. If I say localized vascular and cellular response of the body to injury, what I mean is that we will be looking at the vascular response of the body to injury and then the cellular response of the body to injury. If your body is exposed to injury, what is the vascular response and the cellular response of the body in reaction to the injury? Again, what are the types of inflammations? We have acute inflammations, chronic inflammations, and subacute inflammations. Acute inflammation is the ability of the body to resist attack and damage by microbes and foreign agents, and also to contain an injury, prepare the grounds for repair of damaged tissues. Acute inflammation, as we all know, acute is something that happens suddenly. And once it happens suddenly, the body is able to resist the attack and damage by microbes. And we will look at how the body resists the damage of microbes and other foreign bodies. And we will also see how the body contains an injury or damage. We will also see how the body prepares grounds for repair of tissues. So in our previous definition of inflammation, we spoke about the cellular and vascular response. All of these captures how the body resists attack, how the body contains the injury, and how the body prepares the grounds for inflammation or repair of damaged tissues. So when we talk about the nomenclature of inflammations, inflammation always ends with the suffix itis, with a few exclusions. It is a few inflammations that do not end with the suffix itis. We can talk about pneumonia, which is the acute inflammation of the lungs. We can talk about pleurisy, the acute inflammation of the pleura and the likes. They do not end in itis. But most inflammations end with the suffix itis. So when you take inflammation of the liver, we call it hepatitis. When you take inflammation of the gastric chamber, we call it gastritis. We have peritonitis, which is inflammation of the peritoneum and the likes. Causes of inflammation. We have several agents that causes inflammation. We have the physical agents, we have the chemical agents, we have the microbial agents, we have the immune agents, and then we have the ischemic agents. Physical agents include being injured physically by a trauma, you hitting your hand on a wall, something cutting you, a gunshot, and the likes. And then we have the chemical. We have chemical agents like corrosive esophagitis. So when in a disease like gastroesophageal reflux, the jet disease, when you eat and then there is a reflux of the abdominal content back into the esophagus, because the abdominal, the stomach or the gastric chamber contains hydrochloric acid. And then when it ejects back into the esophagus contains cuboidal cells, and it doesn't withstand acid. And so the acid will eat off the walls of the esophagus, leaving an injury, okay? That injury too undergoes inflammation. And when such an injury happens as a result of gastroesophageal reflux, we say that the cause of the inflammation is by chemical agents. We have also microbial agents. Viruses and bacteria, fungi, protozoa causes inflammations. And when that happens, it is caused by microbial agents. We also have immune agents like pollen, house dust. People have allergies to house dust and the likes. So when they inhale house dust, what happens is that their respiratory tract, the mucosal lining, experiences inflammation. And when such an inflammation happens, we say that the cause is by an immune agent. We have ischemia or hypoxia. This usually happens to the blood vessels and then the brain. So when there is inadequate blood supply to a certain part of the body, the part experiences an infarct or ischemia. It also happens with the heart, and it undergoes inflammation. When such an inflammation happens, its cause is by ischemic agent. Now we come to the process of inflammation. We are considering the vascular response first. Vascular response first. So under vascular response, the first thing that happens under vascular response, when inflammation happens or when your body is exposed to injury, the very first thing that happens is transient vasoconstriction. When we say transient vasoconstriction, what we mean is that transient means immediate, vaso means vessel, constriction means narrowing. And so there is an immediate vessel narrowing. Why is there an immediate vessel narrowing? There's an immediate vessel narrowing because it is the body's positive feedback mechanism to ensure that the body does not lose a lot of blood whilst you have been exposed to injury. Even before clotting comes in, the body experiences transient vasoconstriction to ensure that the body do not lose a lot of blood before clotting factors come into play. So when you are exposed to injury, the first thing that happens is transient vasoconstriction. Immediate event after an injury is transient due to sympathetic stimulation by the injurious agent. This is to control blood loss from bleeding and to allow time for clot to plug bleeding. Right. So that is with transient vasoconstriction. The next one is persistent vasodilation. Persistent vasodilation. After transient vasoconstriction, they lead us to persistent vasodilation. This happens by release of some vasoactive substances. Vasoactive substances like histamine and complement 3A and 5A bradykinins, which are all components of the blood in case an inflammation happens. This comes to widen the vessels to ensure that the needed ingredients to prepare the grounds for the repair of damaged tissues come into play. So why does persistent vasodilation follow transient vasoconstriction? When transient vasoconstriction happens, I have told you earlier that it happens so that the vessels will close up to ensure blood is not lost, or not more blood is lost to the external environment. So afterwards, clotting factors come into place, and then there is a formation of scab, which we will talk about under wounds. There is a formation of scab. After transient vasoconstriction, there is a tiny tissue that comes to lay off on the surface of the wound, which we call scab. That prevents blood from exiting to the external environment. After that has happened, now the wound is ready to ensure ingredients that is necessary for repair of damaged tissues come into play, and so there is persistent vasodilation. The vessels dilate. And how does the vessel dilate? The vessel dilates by the help of some vasoactive substances, which are all components of the blood, and that one is secreted by the sympathetic nervous system. Then there is increased vascular permeability. Increased vascular permeability. What happens is that in between your blood vessels are tight junctions. The individual cells of your body are held by something we call desmosomes. And then the desmosomes hold the cells so tightly together such that it creates a very tiny holes in them, in between the individual cells, that is called the tight junction. When these desmosomes hold these cells together, that is the reason why our cells or our body is very tough, because desmosomes holds the individual cells together. That is desmosome. That is the work of the desmosomes. When an injury happens to your body, the very part that the injury happens, vasoactive substances make sure that the work of the desmosomes declines. And so the desmosomes, which ordinarily will hold your cells so tight, will not be able to hold that part of the cell so tight because it is being counteracted by vasoactive substances. And when these vasoactive substances counteract the desmosomes, it causes the individual cells to widen up. And when these individual cells widen up, that is when the appropriate ingredients, the appropriate components of the blood necessary for wound healing exit out of the widened gap junction and go to prepare a favorite grounds for wound to heal. So what I am saying under increased vascular permeability is that the vasoactive substances go to counteract the desmosomes and then widen the gap junction, enhancing other components of the blood to get to the part where the inflammation is happening. Once the appropriate ingredients gets to the part where inflammation is happening, there is exudation of fluid, there is accumulation of fluid at the part where the inflammation is happening. That is the more reason why the cardinal signs and symptoms of inflammation include swelling, because there is widening of the gap junction, and then there is exudation of fluid. Fluid exits from the blood vessel to the external environment to ensure that there is other activities that will prevent bacteria from thriving at the part of the inflammation, and also other activities that will enhance the damaged cells to be repaired. Moreover, that is why with the cardinal signs of inflammation, there is warmth, because blood accumulates at the part of the inflammation, and then the temperature of the blood will assume the same temperature of the location that the inflammation is happening. And of course, the blood contains more red blood cells, and so the part where the blood is accumulating will assume the coloration of the red blood cell, and so there is reddening during inflammation, right? So tissue distension as a result of accumulation of, that is basically what I have explained earlier, how the cardinal signs of inflammation can be related to the physiology of inflammation. So tissue distension as a result of accumulation of exudates as well as nerve endings that will create pain. The exudation of the fluid to the area will dilute injurious and supply neutralizing substances to nullify their effect. The fluid is serous but becomes purulent when secondarily infected, or if injurious agent is bacteria. The cellular response is carried out by many cells in the body. Okay, so let's move on. Right. So now we are done with the vascular response to inflammation, and we are moving on to the cellular response to inflammation, or cellular response of acute inflammation. So with the cellular response to inflammation, the first thing that we will talk about is margination. The cells predominant in acute inflammation is neutrophils. They move to the periphery of the blood vessel known as margination. So the ingredients that I kept mentioning, one of them is neutrophils. And during inflammation, neutrophils play most of the role in inflammation. So neutrophils move to the periphery. When we say the periphery, to the walls of the vessel. They move to the walls of the vessel. When neutrophils move to the walls of the vessel, that is what we are calling margination, and is the first vascular response to inflammation. Now, neutrophils coat the inside of the vessel in a process called pigmentation. So when the neutrophils go to line up at the wall of the vessel, they create something like a pavement. A pavement is like comparing an untarred road to a tarred road. So an untarred road is a vessel that has not been injured, because an untarred road, a vessel that has not been injured doesn't have any neutrophil lining the wall of the vessel, and so an untarred road is a normal vessel that doesn't have any injury. The tarred road is the vessel that has been injured because neutrophils has moved to the periphery and then lying off the walls of that particular vessel. And so with that particular vessel, with the use of a microscope, you would see that neutrophils are lining in the walls of the vessel, which we are calling pigmentation. The neutrophils are able to pass through the widened gap junction. We also spoke about increased permeability. So the neutrophils passes through the increased gap junction created by the permeability, and that one we are calling it as emigration or diapedesis. Right. So still continuing on the cellular response of inflammation, neutrophils movement throughout the inflamed area to where the pathogens and foreign bodies are known as chemotaxis. Chemical taxi. So if you want to remember it easily, chemical taxi move, and this one it is a taxi moving a chemical. So before the neutrophil get to the pathogen or the foreign body, there has to be chemotaxis, and chemotaxis is aided by chemoattractants. Example is complement 5A or bacteria proteins. The bacteria, their presence come with a certain chemical that makes sure that it attracts neutrophils to anywhere that it is in the body. They produce certain proteins that attracts neutrophils to the site where it is found. And for the neutrophil to move to where the bacteria is, that process is called chemotaxis. Chemotaxis. Once the neutrophils reach the pathogens, they extend their cytoplasm like pseudopodia of an amoeba and engulf them. So the wall of the neutrophil is very, very flexible because it doesn't have any cell wall. And once it doesn't have cell wall, it just extends its cytoplasm and then engulf the whatever pathogen it is. And then it eats it off with a substance called the lysosomes. For neutrophils to engulf the pathogen, it is necessary for the pathogen to be coated with certain substances, just like garnishing of the food. So bacteria in itself cannot attract neutrophils. Neutrophils on itself cannot attract bacteria unless it is garnished. So what we are trying to say is that the bacteria in its raw state cannot be attracted by the neutrophil. It has to be garnished. And the garnishing of the neutrophil is done by immunoglobulin G or complementary B. All of these are components of the blood. Okay, so just garnishing of the bacteria attracts the neutrophil, and that process, the process whereby there is garnishing of the neutrophil there's garnishing of the bacteria before neutrophil engulf it, is what we are calling opsonization. Opsonization. Okay, so we are back to pathogen killing. Pathogen killing. How the pathogens are killed after it is engulfed by the neutrophils. The engulfment of the pathogen by the neutrophil is what we are calling phagocytosis. That is what I said we will come to. The engulfment of the pathogen by the neutrophil is termed phagocytosis. Inside of the neutrophil are certain chemicals, that is the lysosomes, which are released to kill the pathogen. If it is released, if the neutrophil releases the lysosomes on the bacteria outside, it doesn't engulf it. If it releases the lysosomes on the bacteria outside, it is called extracellular killing. When the neutrophil engulf the bacteria and kill it inside its cytoplasm, we call it intracellular killing. Intracellular killing. So with pathogen killing, we have intracellular killing and extracellular killing. Okay. Now we have already discussed the cardinal signs and symptoms of inflammation, which include tumor or swelling, rubor, redness, color, which is warmth, dolor, which is pain, functionalesia, which is loss of function. Of course, due to the pain that is associated with the site of inflammation, you are unable to use the parts that an inflammation is happening. That is what we are referring to as loss of function. Adverse effect of inflammation. Some of the adverse effects of inflammation. Inflammation is a very important process that needs to happen in the presence of an injury. But what are some of the adverse effects of inflammation that the body goes through? Excessive swelling leads to disruption of tissues. How and why will it lead to disruption of tissues? If there is excessive swelling, massive swelling at a body part, what it does is that it destroys nerve endings. We said under cardinal signs of inflammation that during inflammation, nerve endings are irritated. That result into pain or dolor in cardinal signs of inflammation. So when there is excessive swelling or excessive swelling in inflammation, what happens is that there is nerve damage, because the inflammation will extend pressure to surrounding nerves inhibiting blood supply to the nerves and thereby damaging the cells of the nerves. So that is an adverse effect of inflammation. In as much as inflammation is a very important process, excessive swelling can also result in disruption of tissues and nerves. It can result in disruption of tissues and nerves. Disabling pain from excessive swelling and nerve irritation. Disabling pain from excessive swelling and nerve irritation. Of course, when there is excessive irritation of the nerve as a result of excessive swelling, what comes about is pain, to the extent that the person will not be able to use the part at all. That is what we are describing as disabling pain from excessive swelling and nerve irritation. Pressure necrosis on neighboring structures. As I said earlier, if there is excessive swelling, blood supply to neighboring tissues and nerves become impaired, and for that matter there will be necrosis. Progression to systemic inflammatory response syndrome. So what happens is that one of the adverse effects of inflammation is that permanently the person experiences inflammation of the part. Usually when people get fracture and there is a tear of surrounding tissues, you realize that if the fracture happened on the left leg, if you compare the part where the fracture happened to the part which was not, or that doesn't have any fracture, so if you compare the left leg that got fractured to the right leg that got fractured, you realize that the left leg that got fractured, the part where the fracture happened, experiences inflammation throughout the person's life, or significantly throughout the person's life, and that is what we are calling systemic inflammatory response syndrome. It gets to a point in time that the person permanently experiences an inflammation of the particular part. So the little trauma that is extended to the part further becomes swollen. Excessive high temperature, which may lead to convulsion, especially in children. Of course, we all know that poor management of fever in children leads to convulsion. So it is associated with inflammation, especially when there is excessive inflammation in an individual, especially in a child, it leads to convulsion. Now, benefits of inflammation. If we have recounted a lot of benefits of inflammation, especially we know that inflammation helps damaged tissues to get repaired. We know that inflammation prepares the grounds for healing. We also know that inflammation brings the needed nutrients to enhance wound healing and the likes. Some more of the benefits of inflammation include it contains minor infections before they become overwhelming. So even before infections gets out of hand, the process of inflammation is instituted or initiated to ensure that the process of infection or infection process do not get out of hand by the secretion or the arrival of neutrophils to the site of inflammation prevents further or overwhelming infection happening at the site of inflammation. So that is a benefit. It causes dilution of toxins. So due to the fluid exudation, which is part of the process of inflammation, any toxin that is present at the site of inflammation gets diluted due to the high volume of fluid that exudes to the site of inflammation. It destroys offending agents. So offending agents like viruses, bacteria, and others are destroyed by neutrophils, which we described under pathogen killing, intracellular and extracellular killing. It destroys, one of the benefits of inflammation is that it destroys offending agents by the help of the neutrophils. It alerts the body to the threat of injury. It leads to the production of protective antibodies against future infections of the same kind. We all know that when our body comes in contact with any pathogen, the immune system is in place to fight that pathogen. And after the immune system fight that pathogen, antibodies are created in the blood. And so in the case of any future occurrence of similar pathogens or same pathogen, the antibodies are already in place to battle the pathogen. So that is also another benefit of inflammation. It leads to fibrin formation to confine and localize inflammatory process. It leads to the formation of fibrin, which is a part of the clotting process. It leads to restriction of injury to the smallest area possible. Restriction of injury to the smallest area so that the injury do not get out of hand. The reason why people who are having diabetes, when they get an injury, it doesn't get to heal faster, is that they have very low immunity. People who have diabetes have very low immunity. And so the neutrophils that will rush to the site of inflammation in a person who is diabetic is very, very, very low. And so if there are presence of pathogens, the neutrophils are not able to battle those pathogens, and the neutrophils are unable to battle those pathogens, and the bacteria defeats the body's immunity. And so the activities of the bacteria will result in formation of pus, and then gangrene will be setting in a typical diabetic injury. So in diabetes, due to the low immunity and, for that matter, low number of neutrophils involved in inflammation, their body, when damaged, does not easily get resolved. Right. It results in killing of foreign microbes, which we all know that this is the work of the neutrophils. Right. Outcome of acute inflammation. Outcome of acute inflammation. In acute inflammation, it either gets resolved after it has gone through the process of inflammation, which is the transient vasoconstriction, persistent vasodilation, increased vascular permeability, and then fluid exudation. After these four main processes, the acute inflammation gets resolved, which we are calling resolution, or it progresses to the stage of suppuration, whereby the pathogens that is causing the or that is present at the site of the infection get out of hand. It doesn't. The immunity is unable to control it anymore, and so it gets infected. So it doesn't get resolved. So it moves to the stage of suppuration. And once it moves to the state of suppuration, inflammation becomes chronic. It takes longer period before the inflammation gets resolved, and for that matter, the damaged cells get repaired. Okay, so attenuation of adverse effect. When I say attenuation, all I mean is prevention of the adverse effect, how you would prevent the adverse effect from happening. So we spoke about convulsing in children, and so how you would help the child from having convulsion is management of the fever, which include tepid sponging. Once inflammation is also associated with fever, you can give the individual antipyretics. It is also associated with pain, and so administration of analgesics. Inflammation, the main reason why inflammation happens is that it wants to get rid of certain pathogens, and so administration of antibiotics is also very, very necessary, which will also go and enhance the work that the immunity has already initiated. Right. Now we come to that debridement of wounds. I think we all know the process of debridement. When you go to the ward, you will see that some of the wounds are having a certain yellowish tissues, which is lying on the surface of the wound, which we usually call slough. So the slough is more or less like a parasite. So the blood that comes to the surface of the wound, that will help the wound to heal. The slough shares with the wound. And so instead of the blood getting the full benefit of the supply of the body, the slough shares the blood that the body supplies to the portion where the wound is happening. And so in order to enhance the wound to heal, you must get off this particular parasite, which is the slough. So usually this is a surgical procedure that the person is sent to the theater, and then debridement is done either physically or with the use of chemicals. Right. We also have incision and drainage of abscess. So if the inflammation progresses to the stage of suppuration, and then there is accumulation of pus, we can do, or we usually do, incision and drainage. The part where the inflammation is happening is incised. Is penetrated into with the use of syringes, for example, and then the pus is drained out. Okay, and then in the case whereby the wound gets so terrible and it's not healing, and then further cells get more damage, gets to damage. You know, inflammation is to help damaged cells to get repaired. So if damaged cells are not getting repaired, and rather more cells are getting damaged, what happens is that there has to be an amputation to save the rest of the cells from getting damaged. So one of the ways of preventing adverse effects of inflammation include amputation of dangerous limbs. So characteristics of acute inflammation. Acute inflammation, as we all know, is immediate. Acute means sudden, so it's immediate. That's one of the characteristics. Duration is 1 to 2 days. The duration of acute inflammation is 1 to 2 days. So it's 24 hours to 48 hours. Predominant cells involved are neutrophils in acute inflammation. The predominant cells involved in acute inflammation are neutrophils. The lifespan of the neutrophil is within 10 hours. So it dies off, and then more are supplied to the part of the body. Healing leads to return to normal function, which is also a characteristic of acute inflammation, because it doesn't take much time. It takes a duration of 1 to 2 days, and then it gets resolved, and then wound healing gets in place. Right. Now, characteristics of chronic inflammation. Chronic inflammation. Onset delayed till 48 hours. So after it moves from acute stage, which we are saying that the duration is from 1 to 2 days, it gets chronic after 48 hours. The duration of chronic inflammation is 2 weeks or more. Predominant cells are macrophages, lymphocytes, and the like. Macrophages are basically neutrophils that are found in tissues. Okay, neutrophils that are found in tissues are called macrophages. Okay, and then we also have lymphocytes, which is also a predominant cell in chronic inflammation. Usually, healing after chronic inflammation leads to scar formation, because healing in chronic inflammation means that it progressed to the stage of suppuration. And once it progressed to the stage of suppuration, it means infection set in. And so healing was by secondary intention. And wound healing by secondary intention usually leaves a scar. We will get to wounds, and then you will understand the picture much better. Healing, therefore, may not lead to return to normal function. Why? Because cells that were damaged were not replaced by cells of the same kind. The cells that were damaged, so if, for example, if it is your skin that was damaged, the parts the damage happened were not replaced by epithelial cells, but rather by fibrosis. Okay, and so the rate at which you can twist and turn that part of your hand, you will not be able to do it, the same, because the cells present there is no more epithelial cells, but they are fibrous tissues. Right. So I hope we have all understood inflammation and the process of inflammation. So inflammation basically is the cellular and vascular response of the body to injury. We have acute, chronic, and subacute. And the process of inflammation, we have transient vasoconstriction, persistent vasodilation, we have increased vascular permeability and fluid exudation. We also have some benefits of inflammation, which includes helping, prevent infections and containing the infection process, and also preparing the grounds of the part that is damaged for repair of damaged tissues. We also learned about some of the side effects or adverse effects of inflammation, which we spoke about, convulsion in children. We also spoke about damage to tissues. We also spoke about disabling pain and the likes. We spoke about attenuation of the adverse effects, how to prevent those adverse effects from happening. We spoke about episponging, administration of antipyretics, administration of antibiotics, and the likes. We have spoken about the characteristics of acute inflammation and characteristics of chronic inflammation. So now we are moving on to wound and wound healing. Wound and wound healing. Wound and wound healing. During first aid, wounds were introduced, and I know you all know something about wounds. Wounds and wound and wound healing was introduced during the first aid lesson, and so I know most of you know about wounds. Just as we define wound is a break in the continuity of the tissue, which may or may not involve the overlying epithelium, and I know you will all understand that by now. A wound is different from an ulcer, which is a break in the continuity of epithelium. So a break in continuity of epithelium specifically is what we are calling ulcer. But with or without the overlying epithelium is a wound. Wound healing is the replacement of damaged tissue by another tissue, which is usually fibrous tissue or scar. Right, we have classification of wounds. We have wound healing by, classification. We have mechanism of injury. Mechanism of injury refers to how the injury happened. How did the injury happen? Is it that you hit your head against a wall, or you stumbled on a stone, or you fell? You were involved in an RTA. How did the injury happen? That is mechanism of injury. Degree of contamination is the extent to which the wound is at risk of infection. The extent of risk of the wound to infection is degree of contamination. Degree of visibility is whether the wound can be seen physically or it cannot be seen, but it is internally. It's internal. It's either it is external or internal. That is the degree of visibility. So, under types of wound based on mechanism of injury, we have abrasions or abrasions. It is a superficial wound which usually involves only minimal loss of cells. Usually, that is what we call bruises. It is not deep. It is very, very on the surface. It is very shallow and doesn't involve massive loss of cells. So that is with abrasions. Now we come to incisions. Incisions are very planned and therefore are under sterile conditions. So usually the wounds that we get or sustain from surgery is an incised wound. If for some reason you are cutting your nails and then you cut a toe, your toenail with the blade, that becomes an incised wound, because usually incised wounds are caused by sharps and the edges are well defined. Okay, so that is with incised wound. It is usually called the surgical wounds. Contusion is, as I mentioned earlier, it is a blunt injury. So if someone gave you a big fist on your chest and then you don't really experience a physical injury on the outside, but the part become swollen, that is a contusion. or someone give you a dirty one on your chin, and then you sustain a swelling on your chin, that becomes a contusion. Someone hit your forehead with a stone. There is no obvious break in the continuity of the skin, but there is a swelling. That is a contusion. This may be deep without significant commensurate injury to the overlying skin. Still on types of wound based on mechanism of injury, we have lacerations. This is similar to surgical incision as they both involve a cut, but here it is not under sterile condition and the edges are rough. Lacerated wounds are usually sustained in accidents, road traffic accidents, and so people come to the hospital with wounds from RTA, and most of the wounds that you see from RTA come with rough edges, extensive loss of cells, and extensive loss of blood vessels and nerves. Those are lacerated wounds, right? The rough edges and all. Punctured wound, there is a little damage to the external, but deeper into the cells. So, for example, when you take an example of a punctured wound, we have gunshot. If you look at the part where the pellet entered the body, you realize that it is a tiny wound that will be formed there. But beneath that tiny wound is a deep destruction of cells. That is typical of a penetrated or punctured wound. When someone gives you a stab with a knife, you realize that on the outside, it is only the opening that the knife entered into the part of the body that will be, that is where the wound will be created. But beneath the part of that small wound is an extensive cell damage. It's an extensive cell damage. And that is also an example of a punctured wound. And usually, punctured wounds are prone to tetanus infection due to the anaerobic environment created. Most of the cells that are beneath that are damaged are not getting oxygen. And so tetanus infection thrive in such cells more than a lacerated wound where the cells are all exposed to oxygen. Tetanus is unable to thrive on such wounds, but is able to thrive better on punctured wounds. Avulsion is when there is a considerable loss of tissue. So, for example, when someone gets accident and then the part of the hand is off, or even the ear is off, that is an avulsion. A muscle is off outright, is an avulsion. So it is not as if there is an injury and then the cells are hanging, but rather the cell is off outright. That is an avulsion. Okay, so types of wounds based on degree of contamination. Under degree of contamination, we have clean wounds, we have clean contaminated wounds, we have contaminated, and then we have dirty wounds. Under clean wounds, the risk of infection is less than 2%. And example of clean wounds are usually wounds on the eye, the skin, or the vascular system. Mostly, clean wounds are wounds that are found inside of the body. So it is not exposed to the external environment. Right. Clean contaminated, this may not show signs of infection. It is at risk of becoming infected because of its location. For example, the surgical wounds in the gastrointestinal tract may be at a higher risk of becoming infected. The risk is between 2 and 5%. Why is the wound in a gastrointestinal tract at risk of becoming infected than a clean wound? Because in the gastrointestinal tract, food is always moving up and down, and then these food particles is likely to enter into the wounds, and then bacteria is also likely to thrive in such medium and then survive. So wounds that are along the gastrointestinal tract are also at risk, and it is between 2 to 5%. It also includes the respiratory system as well. Right. Contaminated wounds are wounds that are exposed, a surgical wound in which an outside object has come into contact with it. So wounds that are exposed considerably are contaminated wounds, and its risk is 5 to 10%. Dirty wounds are a class of wounds that are very dirty, especially wounds that comes out of accident. It comes with dirt, grasses in it, fecal matter, and all of that. Dirty particles found in the wound. So such wounds are described or categorized as dirty wounds. Dirty wound. Right. Types of wound based on degree of visibility. So under degree of visibility, we have open wounds and we have closed wounds. So open wounds are wounds that there is a break in the continuity of the skin, but a closed wound is one that there is no break in the continuity of the skin, especially in the case of a contusion. And then with open wounds, lacerations are open wounds, punctured wounds are open wounds because they are open to the external environment. But with the contusion, there is no obvious break in the overlying epithelium. Okay, so replacement of damaged tissues. Replacement of damaged tissues. How does damaged tissues get replaced? How do they get replaced? So I was talking about healing by primary intention, by secondary intention. So how does damaged tissues get replaced? It gets replaced by regeneration or by fibrosis. Regeneration is replacement of cells of the same kind without any evidence of previous damage. So regeneration, replacement of lost cells by exactly same type, such that there is no evidence of previous damage. So that is regeneration. Cells of the same kind replaces the damaged ones. However, process of regeneration in man is imperfect. The closest example of regeneration in man is regrowth of the liver post-hemihepatectomy. So after a portion of the liver is taken off, the liver produces cells of its own kind and then replaces the part of the liver that was removed. And that's a typical example of regeneration in man. There are different types of cells with respect to ability to regenerate. And then we have grouped them as labile cells, stable cells, and permanent cells. Okay, so labile cells are cells that can regenerate fully and actually do so continuously as one lives. I don't know if any one of you has a scar in your mouth. A scar in your mouth. The mucous lining your mouth replaces damaged ones with the same kind every day. The endometrium of a woman is shed off monthly in a process of menstruation. And cells of the same kind replaces the endometrium without scar. Okay, the wall of the esophagus undergoes regeneration when it is scarred. So such cells are what we are calling labile cells. They regenerate, they undergo regeneration, they produce cells of the same kind without evidence of previous damage. That is why when you look at the inside of the woman's, the uterus, you don't see any scar. Stable cells. Under normal circumstances, these cells are dormant, but when stimulated, can attempt to regenerate. Example is the liver cells and osteoblasts, bone cells. They are stable cells. They can replace cells of the same kind, but it is not always the case that it produces cells of the same kind. Sometimes it produces cells of the same kind and yet leaves some callus formation, which may not look exactly like the cell of the bone or osteocytes. So, of course, the bone cells produces cells of its own kind when it is fractured, but it is not always the case that it produces cells of its own kind. Sometimes it produces other cells, that is, callus formation, which doesn't look exactly the same as osteocytes. Then we come to the permanent cells. The permanent cells do not undergo regeneration. Once damaged, it remains damaged. Typical example of such cells are cells of the brain, the cells of the spinal cord. That is why when we were talking about spinal injury in first aid, I told you the cells of the spinal cord is made up of specialized cells. Once damaged, forever it remains. So if you get an injury to your spinal cord, it is unable to regenerate cells of the same kind. And so cells of the spinal cord are permanent cells. Cells of your eye is a permanent cell. It doesn't, go undergo regeneration. Cells of the brain are permanent cells. It doesn't undergo regeneration. Once damaged, it cannot replace cells of the same kind. So these are some of the examples of permanent cells. That is why when someone gets spinal cord injury, the person becomes permanently paralyzed, because the spinal cord has sections, and each part and where it controls the body. Okay, so we have the cervical spine, which controls movement of all the limbs, your legs, your hand, your legs. So once the cervical spine is torn, you are unable to move your limbs, your legs, and then your hand. Okay. Specifically, the C4, C6 portion of the cervical spine, when damaged, that is the part that controls respiration. And so you realize that the individual is always in respiratory distress. Okay, so spinal cord, once damaged, cannot be replaced, and for that matter, it is made up of permanent cells. Okay, so that leads us to regeneration, and then the cells that undergo regeneration and the cells that do not undergo regeneration leads us to the process of wound healing. And in the process of wound healing, we have primary intention, and then we have secondary intention. Primary intention, wounds that are healed under primary intention usually do not leave any scar, but wounds that are healed by secondary intention leaves a scar. Wounds that are healed by primary intention do not undergo any infectious process, or the immunity is able to contain the infection, but wounds that heal by secondary intention, the immunity is unable to contain the infection process, and for that matter experiences some infection process. Right. So wound healing by primary intention involves the following steps. So hematoma and scab formation, epithelialization and wound contraction, acute inflammation demolition process. We have organization and granulation tissue formation, maturation phase, and then remodeling. Right. Hematoma and scab formation. Hematoma and scab formation. This is the first stage of wound healing. Hematoma and scab formation is the first stage of wound healing. Subsequently, a clot or hematoma forms together with a transient vasoconstriction to stop further blood. When this dries up, it forms a scab. When I was talking about transient vasoconstriction, I said that the transient vasoconstriction comes into play before the process of clotting happens. And once the process of clotting happens, it leaves a clot. It leaves a clot. It forms a plaque. The plaque is what obstruct blood from exiting to the external environment. And when this clot or plaque dries up, we call it a scab. The scab serves to cover the surface of the wound and prevent secondary foreign body and bacterial invasion, as well as protects underlying tissue from drying up. Okay, so the scab also allows healing to take place underneath without any disturbance of the new fragile tissue by external factors. Okay, so that is with hematoma and scab formation. The scab helps the entry of pathogens into, help prevent the entry of pathogens into the wound. So now we move on to epithelialization. With epithelialization, there is lay down of epithelial cells on the surface of the wound. Lay down of epithelial cells on the surface of the wound. So the epithelial cells are laid down in a horizontal fashion. It's laid down in a horizontal fashion. So the epithelial cells, when someone gets a wound, the epithelial cells start from one corner and then the other corner, and then the epithelial cell starts forming in a horizontal fashion. Horizontal is like this. So one starts from here, then the other point starts from here. So it comes like this. And once the epithelial cells gets contact, there is cessation of further laydown of epithelial cells, which we are calling contact inhibition. Contact inhibition is when one epithelial cell moves in a horizontal fashion to meet another epithelial cell to ensure an absolute cover-up of a wound. So once one epithelial cell hits the other, coming from opposite direction in a horizontal fashion, there is cessation of further laydown of epithelial cells, which we are calling contact inhibition. Once these epithelial cells are laid down, it contracts or reduces the size of the wound with the help of myoepithelial cells. So these myoepithelial cells are smooth cells that comes with the lay down of epithelial cells. So once they are laid down, it just brings the edges of the wound together and further contracts the wound and reduce the size of the wound. Okay, so now we move on to acute inflammation. Acute inflammation. Below the new epithelial cells, acute inflammation occurs to bring in needed inflammatory cells to clean up the wound and make it ready for healing to start. The wound therefore manifests all cardinal signs of inflammation at this stage. So with acute inflammation happening at this stage, all the cardinal signs and symptoms of inflammation manifest at this point of the wound healing. So now there is demolition. Demolition is after inflammation has happened, after neutrophils arrive at the site where the wound is happening, it starts to take off bacteria, it starts to take off dirt, it starts to take off other unwanted bodies from the surface of the wound, which we are calling demolition. Just as the AMA demolish the Accra streets when market women are sitting left and right of the road, and then they come and then they tell them to move away. After they move away, you realize that the pavements have all become vacant and then movement become easy. That is the very work that the neutrophils does. When it goes to the site of the wound and then there is foreign bodies, sand, fecal matter and the rest, it goes to clear all of them and then make sure that the wound is cleared, and now it prepares ground for repair of tissues. During this stage, the wound is seen to be in a lag phase. A lag phase in the sense that healing process becomes stable. The wound physically do not experience any change. During the stage of demolition, the wound healing is in a halt. So if someone is having low immunity and then the person takes extra more days for demolition to happen, it means that the wound healing will be prolonged. If someone is having low level of neutrophils, and at the stage of demolition, the neutrophil is the major actor in play. It means that the neutrophil's work will be overburdened, and so the ability of the neutrophils to get the wounds cleared will also be at a slower pace. And so the wound would take a higher number of days or a good number of days to heal, which ordinarily wouldn't have been so. Right. So with the lag phase, this takes 3 to 5 days, during which the preparations are made prior to actual healing. Still on the process of wound healing, we come to organization of granulation tissue formation. The whole healing process is initiated and controlled by growth factors. Fibroblasts are another group of cells recruited to the wound site. They lay down collagen to bridge the wound edges. The growth factors stimulate new blood vessels to sprout out in loops in the floor of the womb. This loops of new blood cells in the collagen matrix under microscope has a granular appearance, hence the descriptive term granulation tissue formation. So the collagen that is laid down to repair the destroyed capillaries has a granular appearance. That is why we call it granulation tissue formation. Right. So with this stage, fibroblasts are laid down, and then they lay down collagen to bridge the edges of the wound, and this happened in a certain fashion such that granulation tissue or collagen replaces damaged capillaries. And this one, the collagen, when viewed under the microscope, has a granular appearance, and hence the descriptive term granulation tissue. All right. So still under wound healing, the process of wound healing, we are talking about a certain clinical application. So under organization or granulation tissue formation, healthy granulation tissue is pink. So for you to know that the wound is healing well, the surface of the wound appears pinkish, not beefy red. If it is beefy red, it doesn't mean the wound is healing. Sometimes you look or you visualize the surface of a wound and it doesn't have any pus, doesn't have any fluid, but it is reddish. Such wound cannot have a healthy granulation tissue. Rather, a pinkish granulation tissue is a healthy granulation tissue. Healthy granulation tissue does not bleed easily with contact or has no slough. So it doesn't have any slough when you look on the surface, and then doesn't bleed easily when subdued to violence. So on the other hand, an unhealthy granulation tissue has an irregular surface, looks beefy red or pale, and then usually raised above the surrounding cells. So if you look at the wound, it is raised above. It looks swollen, that part looks swollen. And it may have slough with offensive copious discharge and bleeds very easily on contact. Okay, so now we move on to the next stage, from organization and granulation tissue formation to maturation and remodeling. What happens under maturation and remodeling is that the initial collagen that were laid down were immature, so they undergo maturation. The initial collagen is heaped up in a wound, and so it is remodeled. It is remodeled in a certain fashion just to flatten out so that it is at the same level as the surface of the skin. When this process is ineffective or the collagen is released excessively, it leads to hypertrophic scar and keloid formation. So when the collagen that were laid down on the wound were excessive, it means that after the wound has formed, a certain mass or a certain heap up of cells will be formed above the surface of the normal skin. That is what we are calling hypertrophic scar or keloid formation. So now clinical application. So if someone gets a wound, because the person will have to undergo maturation and remodeling, the person has to eat or taking a lot of food containing vitamin C and zinc, because the enzyme responsible for maturation and remodeling of the collagen are hydroxylases and metalloproteinase. They work best in the presence of vitamin C. So that is why when someone gets wound, we encourage a person to be taking a lot of vitamin C so that the process of remodeling and maturation can go on successfully. Collagen is also formed from amino acid, with the most abundant amino acid in collagen being glycine. Others are methionine, proline, lysine. Therefore, adequate protein intake is vital for wound healing. This is the reason the collagen formation is the more reason why someone has to eat a lot of proteins or adequate proteins when the person sustains wound. As collagen is laid down, the wound gains tensile strength, but never to the original level of the non-traumatized tissue. Scars are therefore weaker than the original cells or tissue. So, ordinarily, when you compare a scar to the normal cell looks more stronger than a scar, because a scar is made up of fibrous tissue the normal cell, especially the cells of the skin, is made up of epithelial cells. Okay, so resutured wounds heal faster because the cells have already undergone the lag phase. However, the scar is weaker than fresh wounds. So when a wound is sutured, it skips the stage of hematoma and scab formation. It skips the stage of epithelialization. Acute inflammation is there, and then it comes to demolition because the skin has already, the two skin that got damaged has already been brought into proper apposition and then sutured together. So the stage that it will start from will be the acute inflammation stage, and so all the needed nutrients, ingredients, are brought to prepare the grounds for wound healing to occur. And with demolition, the demolition will follow in a sutured wound, and then it will also experience the lag phase, as I've already said. However, the scar is weaker. Of course, I have said that scars are made up of fibrous tissue, so they are weaker. The maximum rate of gain of tensile strength is between 10 to 14 days from the start of the process of wound healing. This explains the removal of stitches after 10th day postoperative. So the wound gains tensile strength between, after a wound is sutured, it joins together and then gain tensile strength. Tensile strength means that it joins or fuse together such that it cannot be eviscerated. So that happens between 10th to 14th day. This is what happens with sutured wounds. That is the more reason why usually during the 10th day post-operative, stitches are removed. And with the removal of stitches, it also depends on the location where the wound is found. Usually, when the wound is found in the upper extremity experiences a lot of blood supply, and so wounds on the upper extremity heal faster than wounds on the lower extremity, especially wounds on the head. If a stitch is done on the head, it can even be removed on the third postoperatively because the head is well supplied with blood, and so wounds that the head sustains heal faster. And you can also talk similarly about any portion of the upper extremity may be removed faster before even the 10th day. But ordinarily, regardless of the part where the wound is happening, mostly stitches are removed not latest by the 10th day postoperative. Okay, so healing by secondary intention. I have said that after the wound has gone through primary intention, formation of scab formation of hematoma and the scab, we have epithelialization, we have acute inflammation, we have demolition, we have organization and granulation tissue formation, we have maturation and remodeling. This is by primary intention. After the wound has undergone all these stages, it proceeds, and it doesn't heal, it proceeds to the secondary intention, especially when infections set in, the neutrophils are unable to get rid of or contain the infections. It leads to secondary intention. So the inflammatory process in a secondary intention wound is more intense because there is more damaged tissue and then contaminants to clean up. And then there is clinically significant wound contraction, much more than in healing by secondary intention to try and narrow the gap. So healing by secondary intention results in bigger scars than healing by primary intention. Contractures, deformities are also more likely to occur, especially around the joints. So if the wound happened around the joint, it's likely to leave contractures and other deformities. Okay, so factors affecting wound healing. I have categorized them under systemic factors and then also local factors. Systemic factors and local factors. Factors affecting wound healing. So systemic factors are factors that affect the whole body. They are factors that is as a result of the entire body that is affecting wound healing. So if you are not getting adequate nutrients, it affects wound healing by prolonging the days within which wound healing would have occurred. When there is a comorbid state, presence of chronic conditions, more than one chronic condition, hypertension, diabetes, all slows down the process of wound healing. Radiations, chemotherapy, steroids destroys collagen formation, and so once collagen is laid on the wound, someone who is undergoing radiotherapy, especially in people who are having cancer and taking chemotherapy, drugs associated with cancer, they get their collagen destroyed, and so they're taking the medication. The process of wound healing is ongoing. Collagens are laid, and then the radiotherapy destroys it, chemotherapy destroys it, steroids destroys it, and so the wound healing tends to prolong. Age is also one factor, because people who are aged is believed to have low immunity, and if you're having low immunity, it means that you will have a prolonged period for inflammation to occur and subsequent wound healing. So now local factors. Local factors refers to blood supply to the part of the body. So the part where the wound is occurring, if inadequate blood supply is occurring at the part, it means that the wound healing will be prolonged. If there is inadequate supply of oxygen to the part of the wound healing will be prolonged. If there are presence of foreign bodies, which will lead to infection, it means that it will prolong wound healing. If there is mobility, always the wound is being exposed to violence, especially when wound is dressed daily. We have something that we call wound strain. Wound strain. A wound that is not discharging should not be dressed daily, because the fragile fibroblasts that might have been laid down on the wound will be destroyed if you dress the wound daily. So the fibroblasts are laid down, you go and clear them up by dressing, and then another day, the next day you dress again. That is wound strain. So the wound doesn't get healed. Then we have the surgical technique. So the technique with which the surgeon used will also determine whether the wound will get infected or will not get infected, whether the surgery was under an aseptic technique or not. That will also determine the rate at which the wound will heal. Okay, so now we come to diabetes and wound healing. I have told you that people that have diabetes have a suppressed immunity, so they are experiencing immunosuppression. The inflammatory cells are not effective in cleaning the wound in diabetic patients as in a non-diabetic patient. Chemotaxis is very sluggish. Opsonization is not effective. Phagocytosis is very impaired due to the low immunity. What enhances chemotaxis? Chemotaxis is when the neutrophils is attracted, or is able to move to the site where the pathogens are found. So if the person is having low immunity, for that matter, low level of neutrophils, it means that little amount of neutrophil will move to the site of the pathogen, and then the pathogen is, it's not likely to get defeated, and so it's not contained, and it gets out of hand. Opsonization is also not effective. If opsonization is not effective, it means that the bacteria is not garnished by immunoglobulin G or complementary B. And once that happens, it means that the neutrophil will not attract the bacteria, because I have said that if the bacteria is not garnished, the neutrophil will not get to the bacteria, and then phagocytosis will also be impaired. So the high glucose level in the tissue also make a good substrate, because people who are having diabetes, they have a lot of glucose in their blood. It also serves as a good substrate for bacteria to survive and multiply. For all these reasons, the lag phase is prolonged and the whole healing process is very sluggish. That is what happens with people who are having diabetes. Wound debridement. I have said that wound debridement is the removal of slough or devitalized tissues at an inflamed or wound site. Debridement cleans up the wound and facilitates healing. Debridement is achieved by the following means: either mechanical debridement, biological debridement, sterile or Lavie debridement, or chemical debridement. I will tackle only chemical debridement and mechanical debridement because that is what we usually do in our part of the world. So mechanical debridement is just physically, surgically cutting or scraping off the slough from the surface of the wound. And then with the chemical debridement, the use of fibrinolizing and collagenase to remove dead and other tissues from the surface of the wound. We also have certain chemicals like hydrogen peroxide, which has been stopped by the Ghana Health Service because the hydrogen peroxide tend to eat off the cells of the wound and make the wound very much deeper, and it also impedes the process of wound healing. And so hydrogen peroxide is part of the chemicals that is using debridement, but it is on hold because of its side effects on the wound. Right, so we have wound dressing, how to dress a wound effectively. The first layer of wound dressing should be a Vaseline gauze. Why should it be a Vaseline gauze? Because it's a non-adherent dressing. Okay, it doesn't stick to the surface of the wound. Why shouldn't the first layer stick to the surface of the wound? It shouldn't stick to the surface of the wound because when you are removing an old dressing, if it has stick to the surface of the wound, it will destroy the fragile fibroblasts. It will destroy the newly laid down epithelial cells. And for that matter, it will delay wound healing. So all the time, what you have to do is to place Vaseline gauze as the first layer in wound dressing. Absorbent is the second layer. So an absorbent like a gauze should be right after the Vaseline gauze in order to be able to absorb the secretion or the fluids that may be coming out of the wound. And then you put a crepe bandage, which is very expansible. The expansible nature of the crepe bandage is to accommodate swelling from fluid exudation. I have told you that the last stage of inflammation is fluid exudation, and so if you use an expansible crepe bandage, it is able to allow and accommodate fluid exudation or swelling in case it happens. Right. We also have to talk about wound drains. Wound drains are used to flow fluid, exudate, and blood out of wound site. They serve to prevent hematoma and seroma formation. So when there is an accumulation of fluids, with the help of wound drains, we are able to drain out those fluids, especially in people who are having subdural hematoma. Someone who falls on the ground, hit the head against the ground, and then there is accumulation of fluid. For example, in the skull. So a surgery is done, and then a tube is inserted into the head, and then a collecting bag is also attached, just to make sure that the blood that has leaked out of vessels into the intracellular, the cephalic spaces will be able to exit through the wound drain. Right. So the drainage may be passive or under suction. It may also be closed or open. Closed and suction drains are preferred to minimize it. Example of wound drains are annulation drains, corrugated drains, some drains. Okay. So wound drains, care of a wound drain, daily chart of color, quantity, state of the drain site, and odor of the fluid drained, change of dressing as often as necessary, strict aseptic technique. So this is how to care for a wound drain. There has to be a chart that you will monitor the color of the wound, the state of drainage, the odor of the fluid drained, change of the dressing as often as necessary, and then you also have to dress the site using an aseptic technique, strict aseptic technique for that matter. Complications of wound healing. Complications of wound healing. Early complications include bleeding. So if the body lacks some of the clotting factors, the person is likely to bleed profusely. Or if the person gets an extensive destruction of cells, the person is likely to bleed There is also hematoma formation. There is infections. The person stands chance of getting infections, and also dehiscence. If the part of the body is subdued to massive violence, the part will get eviscerated, or it will get gipped. Late complications. Late complications include weak scars, incision hernias, implantation cysts. We have hypertrophic scars, hypopigmentation, keloid contractures, deformities, chronic ulcers, malignant change. These are all late complications of wound healing. Now let's talk about grafts and flaps. Grafts and flaps. These are plastic surgery, for that matter, which are done to beautify the site where the injury happens. So grafts and flaps are tissue borrowed from other parts of the body or other humans or different species to cover wound defect. These are needed for huge defects and areas where wound contractures is likely to occur. So grafts have no vessels of their own, so they get blood vessel from the recipient. So the tissue that you get doesn't have any blood vessel from the donor, but the blood vessel is taken from the recipient. So when that happens, it is called graft. But flaps have their own blood vessels taken together with them from the donor side to the recipient. So that's the difference between graft and flaps. Graft and flaps all helps to cover up huge defect, especially in areas where wound contractures are likely to occur. Modern trends in wound healing. These are some investigations, research that is ongoing in wound healing. Recombinant human platelet-derived growth factors is approved elsewhere for use in treatment of wound, especially with people who are having diabetes. So this kind of technique is what they are using to help people who are having wounds and are diabetic. So they have done a recombinant human platelet that they infuse, and also growth factor that they infuse into persons who are having diabetes, just to enhance their wounds to heal. We also have skin equivalents. Tissue engineered skin equivalents are available for wounds like venous leg ulcer, diabetic foot ulcer, and the likes. Autologous keratinocytes cultured in human is also used in covering large defects. You know, with venous leg ulcer, there has been artificial vessels that after a portion that has become that has experienced aneurysm. When someone experiences venous leg ulcer, or there is a diabetic foot and then they cut a vessel, they are able to replace with an artificial vessel, which will also act in place of the natural one, and then the person will gain a limb back. All right, so let's move on. Okay, so I want everybody to think about a research topic concerning wounds. So think about the wound healing, the process of wound healing and inflammation and everything associated with it, and then blend it with the clinical experience that you have had during your clinicals, and then think about a research topic, and maybe you can further enhance that research topic, put it in a better perspective, and then you present it in your level 400. So I want everybody to draft a research topic on wounds and inflammation and make it available. I will get all your questions when we are back to the classroom. Thank you.